Welcome, everyone, and welcome back to Pain Science in the Trenches, where evidence meets the realities of clinical practice. I'm Christina Sando, and one of the things I've learned through both clinical practice and my own experience with persistent pain is that recovery is rarely as straightforward as we want it to be. The longer I spend in this space, the more convinced I become that some of the biggest barriers to recovery aren't always found in the body itself. They're found in fear, understanding, loss of hope, past experiences, and in the stories people have been told about what's possible. Today's conversation is about a group of people who often face all these challenges all at once. We'll be talking about pain neuroscience and its role in supporting people with and recovering from substance use disorder. For many clinicians, this can feel like a difficult territory to navigate. We want to help, but we may not feel fully equipped with the right tools, language, or understanding. And for patients, these experiences are often layered with shame, misunderstanding, and the feeling that no one fully sees the whole picture. But if there's one thing that pain science has taught us, it's that understanding matters. The way we explain pain, the way we communicate hope, and the way we build trust can profoundly influence a person's recovery journey. And that's why I'm so excited to welcome Dr. Jessie Podolak, or Podolak, sorry. Jessie has spent decades working with individuals experiencing complex and chronic pain and helping clinicians better understand pain through the lens of neuroscience and integrated biopsychosocial care. She helped develop and lead Evidence in Motion's Pain Science Fellowship and has dedicated much of her career to advancing and the understanding and application of pain neuroscience education. So today we'll be discussing how pain neuroscience can support people with and recovering from substance use disorder, what clinicians need to understand about this population, and how education can become a powerful tool for fostering hope, understanding, and meaningful change. So, Jessie, good morning.
Good morning.
And thanks so much for joining us today. I'm really looking forward to our conversation.
Yeah, me too. Thanks for having me, Christina.
Yeah. So I guess just to start, um, just start by introducing yourself and sharing how your work evolved to include both pain neuroscience and education, or pain neuroscience education and substance use recovery.
Okay, well, let's see. I have been practicing PT for almost 30 years, and I first came across pain neuroscience in 2008, and I would say, so I'd been practicing for 10 years at that time. And the light bulbs and aha moments that went off in my head when I kind of saw the light of, oh my gosh, there's so much more than just a musculoskeletal system, kind of rescued me, I would say, from burnout. Because after 10 years of treating people and really struggling with that approximately third of the population that was in my practice, that it seemed
Mm.
like no matter what I would do, I just was not able to get them. I wasn't able to get them better. It
Yeah.
was really, really freeing to understand the bottom of the iceberg, that sometimes it's not about me. Just people have a lot going on, and a lot more than just the musculoskeletal system. So that was about 10 years into practice. And the first time I attended a P&E class taught by Adrian, um, it was it was the most freeing and exciting thing I had heard in a long time. And I got really excited and then became pretty much a groupie. I have to give a little bit of props to Tim Flynn, who was my instructor for when I went to get my transitional doctorate right around this time. He really laid the foundation in management of lumbosacral disorders. We had a whole week in the hybrid model talking about the biopsychosocial aspect of pain. So it was Tim and then my classmates saying, "Have you ever taken a class on this stuff?" And that was kind of the launch. So, uh, so that was 20 years ago, 18 years ago, and I have
Yeah.
been implementing P&E ever since. Um, And part of P&E, when we talk about pain, there's always very often this conversation about opioids and opioid use disorder. And this was right when kind of the crisis was really coming to the public eye and coming to our awareness, like, gosh, the way we have been working on this isn't working. And in fact, people are dying. And so there, it was in my awareness, from that lens, there was already an intersection, kind of a nice intersection, because of if you're practicing pain science, there is this whole, awareness that there's an opioid problem.
Yeah.
Um, I would also say, so that's kind of, we're going to talk about substance use disorder, um,
Mhm.
and the substances like opioids is what we really often think of, but I will also talk about, I live in Wisconsin. Anybody from Wisconsin here? We like our beer. There's an opiate problem, but there is actually a pretty big alcohol problem. And that's not
Okay.
just Wisconsin, that's everywhere. But
Yeah.
that is something culturally that has been all around me. Personally, it's impacted family, friends. And so that's always been kind of next door to this pain space. And about 15 years ago, I became friends with a gal who actually I saw her a little bit as a patient, knew her a little bit socially, and just became really good friends with this person. And she had a problem with alcohol. And she's one of my best friends today. She's 10 years sober. But her
Oh,
journey in that 5 years of me understanding how pain works, understanding um, a little bit about opioids, having my own personal like baggage surrounding alcoholism, and
yeah.
this friend, watching this friend go through this journey. And she almost died. Her
Oh,
alcoholism almost killed her. Pain was
yeah.
part of her story, but not the biggest part of her story was her substance use disorder.
Yeah.
So those things kind of all came together in my life and kind of
Yeah.
shaped this. And I'm gonna give props to my friend. She made it through her addiction.
Wow.
She got treatment. By the way, she struggled. She tried many times. There's often multiple attempts,
Yeah.
but the final time that it worked, she gives a lot of credit to the sober living community that she was able to residential place where she lived for about
Oh,
6 months after
okay.
treatment. So
Yeah.
she came back to our town and she let things settle for a year or two even,
Mhm.
and then started a sober living facility here. And
Wow.
so, and we were
Mhm.
again good
Yeah.
friends. And
Yeah.
we talked when she was going through her recovery, we talked brain science all the time. Her, like, she
Okay.
was living this experience of rebuilding her brain after years of addiction,
Yeah.
years of alcoholism. And
Wow.
there is a period of anhedonia where there's nothing is fun. There's a danger zone, 3 to 6 months in recovery where it's really easy to relapse because of
Um,
just so I learned so much from her and it got me
yeah.
curious. And as she started, she opened her first sober living home. I want to say she's like I said, she's 10 years sober. I think the first sober living home here is probably 7 years old now. And
Okay.
shortly after she opened, she's like, "Hey, I like this brain talk that you do. Do you want to come over and talk to the ladies about what's going on with their brains?" I'm like,
Oh,
well, of course
yeah.
I do.
Of
So,
course.
so
Yeah.
family night happens on Thursday nights, and that's when I would come. And
Oh,
so it was it wasn't anything I set out to do.
yeah.
It was very organic through
Mhm.
friendship is how I
Yeah.
came to have this
Yeah.
interest in this population. So
It kind of sounds like everything just lined up perfectly
it
to bring you here.
yeah, yeah, I think so. I don't know.
So I'm curious, once you started working with this population, what first made you realize there was a need for like a different approach to pain education in these people with substance use disorder or recovery histories?
Yeah. Well, it's interesting because the way that I have engaged most with this population is in a group setting. But I will say we're all treating people who have substance use disorder all of the time. So in facilities that have a high population of chronic pain or chronic pain specialty programs, 1 in 5 people in those programs is has a comorbidity of a past or present substance use problem.
Oh,
You
is it one
we
in five?
Yeah,
Yeah.
for
Okay.
people in who are in the specialty clinics.
Yeah.
Some For people with substance use disorder, when you look at that group of diagnoses, 40 to 60% of that group is struggling with chronic pain.
Yeah.
So
So this is a
we
big, yeah,
it's a
this is,
big, it's
yeah,
we are
we're
all treating
seeing
them.
it.
So
Yeah.
everybody, you guys are already doing it. You
Yeah.
just might not know it.
Right.
That's one thing to recognize. So is a different approach really required? What I would say as there are certain things that I do focus on a little different when I there is a known substance use disorder, especially when somebody is in active recovery, especially if it's in the early stages. A big a, a big thing is recovery is their number one goal, meaning getting sober. So my goal might be to treat their pain. I want their pain to be better. But the priority, like that's going to happen as their brain heals, or that is a great opportunity to happen. But recovery is so hard. And when a person is actually ready to um, to change their whole life, right? To give up this substance that has been their go-to for coping, for regulation,
True.
their whole life is changing. Their physical pain matters, but it might not be the thing that is the most salient in their life. So I think that part of it is just knowing where I fit in as a support versus, the where and what their priorities are. So
Mhm.
that is a little bit different, is recognizing where somebody is at. So, but the approach, this is the beauty of P&E. The approach, and you, Christina, in your introduction, you worded
Mhm.
that so nicely. So much of what we're already doing in P&E by the nature of P&E is helping foster hope, right?
Yeah.
Gift of neuroplasticity. And the gift of neuroplasticity is a gift for people who are battling chronic pain because we can create new pathways. It's a gift for people who are battling addiction because they can create new pathways. And it's a gift for people who are battling both. And
Yeah.
so P&E is P&E. It's a hope-filled, we explain things much the same. Um, but I think the thing that's different is recognizing this might not be, the pain is only part of the story here.
That's true. And we need to like, yeah, support, maybe just find them where they're at
Yeah,
and support them there.
yeah, yeah,
And then you'll
yeah,
get there eventually.
yeah. And I also, like, for me, I have gotten much more comfortable talking about their recovery. You know,
Yeah,
if they are transparent about it and want to share, I might say, "How's it going?
that's
How
true.
many days are you now? How many days sober?" And
Yeah,
celebrate that with them.
right.
So, or how are the meetings going? Or
Right.
what's new with
Yeah.
with recovery? So a little
Mhm.
bit of comfort level, getting comfortable talking about recovery. It's the kind of taking away some of the stigma. They're just people. They're
Right.
not other. We have a thing, when we kind of label people or we put them into their groups and it can other them. It's like, man, in some ways, I think we are all, who isn't addicted to something, right? Just
Yeah,
some
that's
people,
true.
what they're addicted to is causing such harm that it's totally uprooting their life. And that's where, people get to the crisis. They're like, I have to do something drastic. Um, so I think that normalizing and destigmatizing and just being able to talk, but that is reps and that's being around people. So yeah, I'm
Yeah.
rambling. Go on to the next
No,
question,
no, you're
Christina, because I'm
fine. This is
rambling here.
good. I'm loving it. So, for clinicians who may not work with these patients regularly,
Yeah.
how common is persistent pain in this population? And what are some of the unique challenges they face compared to the average patient we might see in outpatient recovery? I mean, you kind of already touched on some of that.
Yeah, but it's such a good, prudent question because well, first of all, I'll just say that addiction is very heterogeneous. It's like pain. It's like chronic pain, right? Some people have kind of low impact, that chronic thing that's always bothering them, versus like with severity to high impact chronic pain that's just uprooting their life. With addiction, there are people who are functional addicts, functional alcoholics. You've heard that term. They're kind of getting
Yeah.
through life, all the way to very severe. There are people whose addiction um, has kind of really uprooted their life and actually gotten them into some significant trouble. So I see a lot of people in recovery at the sober living homes. We have people who come in after inpatient intensive therapy. We also have people coming in who are coming out from jail or prison, and it's
Yeah.
transitional. Like they're literally putting their lives back together. The
Yeah.
goals in recovery sometimes, you know, so think about this in when working with like a traditional person who's, struggling with chronic pain. Their
Hmm.
goal might be they want to be able to play with their kids again, right? Like they want to get their life back so they can play with their grandkids or their kids or grandkids.
Yeah.
And people with recovery, depending on how their life has gone, their goal might be, I want to be able to visit my kids again because custody
Yeah.
has been, right? Like they
Yeah.
they want to stay out of jail. They want
Yeah.
to, and that's not across the board, but some like the social determinants of health, the environment, there's a lot at stake. There's a lot at stake for everybody. But it seems like the crowd in sometimes in sober living like facilities, it's like, okay, there's big things that,
Yeah.
uh, what do I want to say? Kind of a suburban soccer mom PT like me might not have been as aware of until
Yeah.
I worked with that. So,
Right.
there's some really big struggles, big, scary, sad stuff.
Yeah. Yeah. And yeah, so now you've described a lot of these challenges that this population deals with. So to better understand like where these challenges are coming from, I'd like to talk about like the nervous system.
Mhm.
So, in a history of substance use, or how does a history of substance use affect the nervous system, and
Mhm.
why is that important for clinicians trying to
Yeah,
help understand pain?
yeah. This such good questions that you had, Christina, prepared. So first of all, I would say that the nervous system of a person with chronic pain and the nervous system of a person with addiction share a lot of similarities. There's a lot of overlap. So there is like the reward circuitry. And if you want the best resource, everybody, don't listen to me. I'm not as much of an expert on this as Dr. Anna Lembke. Her book, Dopamine Nation, will help you
Oh, okay.
understand this beautifully, or listen to any podcast with Anna Lembke on it.
Oh,
She's
okay.
such a terrific resource. She's a psychiatrist out of Stanford, and this is her zone, and she is incredible. So I'm gonna give
Yeah.
Dr. Lemke the props and say, listen to that. And here's what I
Yeah.
can tell you is that both chronic pain and alcoholism have a lot of alterations of reward circuitry. So that's
Okay.
one thing that's happening in the brain. Our stress circuitry is also altered in both situations. Dopamine signaling gets altered in both situations. If you understand pain science, you've taken, P&E1, you learn all about the pharmacy in the brain and the top-down regulation that we are capable of as humans. That system gets hijacked in pain. Brain doesn't produce as much of that. It wants to know what else is going on from down there, right? So there's a decreased that endogenous opioids, and that dopamine gets changed in like alcoholism and substance abuse. Those those same neurotransmitters and reward circuitry is being altered by the substance that's coming in and filling in
Makes
like new
sense.
receptors. So, but it's the
Yeah.
same, kind of same, but different a little bit, but the
Right.
same, it's the altered circuitry. Um, the areas of the brain, the amygdala is very involved both in a chronic pain experience, persistent pain experience, as well as in substance use disorder, the insula, the anterior cingulate cortex, the prefrontal cortex. So there's a lot of shared space that there's
Hmm.
overlap in the brain when somebody's got both of those going on. So it's almost like some of the stuff that might be going on for pain is getting egged on even more by what the substance use is doing, and vice versa.
Yeah.
They're kind of
Like
self-perpetuating.
feeding on
They're
each
feeding
other.
each other. Exactly. Yeah.
Are they making
Yep.
each other like each one is becoming more sensitive,
Yes.
kind of in a way?
More sensitive, or what I would say almost just more dysregulated. It's like the
Oh,
pain
yeah.
meeting, the brain meeting story.
Yeah.
The,
Hmm.
like, so if you think about some of those areas, like, man, what should be an area that is really accessible for memory and learning, oh, it's kind of hijacked in a pain experience. P.S. It's also hijacked by substance use disorder. So the capacity to learn
It's
and retain is very impacted. So until somebody is, in recovery and has been able to heal from that, you might be delivering P&E to somebody who's got an active substance use disorder, nothing sticking,
right.
right?
Yeah.
And you're like, why aren't they getting better? Why aren't they
Hmm.
taking this? Why aren't they motivated? Why aren't they? It's because they're in a pain meeting. Plus, there's an amplifier of this substance use disorder. Does that make sense?
That makes sense. And that
Yeah.
explains why some of our like standard assumptions about pain may not fully capture like what these patients are experiencing.
Yeah.
It
Yeah.
sounds like, yeah.
Yeah. For sure. For sure.
So pain neuroscience education was largely developed for the chronic pain population.
Mhm.
What adaptations have you found necessary when working with these people in recovery?
Yeah. So when I think of peony, I remember once sharing the basic story, my favorite story, the one that you could draw, but it's just like here's the wiggle line down here, and then now
Mhm.
it's up here close to the threshold, ding, ding, ding. I
Oh
was,
yeah. Hmm.
just the how you can draw that, right? The sensitive
Hmm.
alarms story. I remember sharing images of that with a patient who was a psychologist counselor, and she looked at me,
Oh,
she said, "Well, duh, Jess. This is a perfect illustration. It's kind of the same thing we talk about for anxiety." And I was like, oh,
right.
wow.
Right.
Okay. And so we got into this conversation about neuroscience is, in some ways, like this
Right.
whole upregulation idea. And so when I think of, adapting P&E to this population, again, it's not necessarily adapting each story because I'm still going to do P&E with that patient. What I'm going to adapt is A, maybe my expectation around their retention. B, the sensitivity with which I deliver it if I suspect, which is the case in a vast majority, there's underlying trauma that is at
Right.
play. Um,
Yeah.
C, I may, again, one of the things I really think is best practice with P&E in general is to work to grow into the clinician that does not talk at your client or your patient,
Yeah.
but that invites them into the story so that it is
Mhm.
um, it's very interactive. How can I help this person make these stories their own? So,
That makes sense.
Yoni's talked about, wouldn't it be like great if we could reframe this or relabel it pain neuroscience communication? So this two-way communication is really, really important. I think that's across the board, but I find it really, really salient with people with substance use disorder who, you know, they want to be involved in their recovery. And so you
Right.
get them actively engaged. So
Yeah.
the stories don't change, but some of
Hmm.
the delivery might a little bit.
That makes sense. Yeah. So it's like the content is similar, but the
Mhm.
context and the delivery just become critically important in this
Yeah.
population, just understanding what else they have going on.
Yeah. And you don't have to be an expert in addiction. It's just being as thoroughly human as you can and being open
Right.
and non-judgmental, and just recognizing, for me, a big aha moment um, this came a long time ago, and it was kind of a lesson in addiction that I needed to hear. Because whether we like it or not, many of us come to this space, and in particular this group of people, with some baggage. We might have had stuff that happened in our youth or with this or that. And I will say, I will be the first to confess, I was pretty harsh and judgmental for a long time because of just the stuff, like nobody chooses to get cancer. People are choosing to drink. Well,
Right.
what might have started as a choice the first time they used, for some people gets its claws in their brain, and
Mhm.
it quickly becomes not a choice. It becomes the thing that they do to regulate their nervous system. Um, and if they don't, it was a conversation I had with a woman. She was an AODA counselor in the prison system, and I happened to be talking to her at a graduation party. And I had that attitude, like they're just it would be. And I remember I said, I would
Oh,
hate your job. I would hate your job because I don't know if I could do that. Um, and and I must have sounded a little judgy when I said it. And she said,
yeah.
I used to feel the same way until I worked with these people. And I realized if it weren't for their addiction, many of them might not even be here anymore because it's
Yeah.
how they were medicating their pain. It's how they
Yeah.
were coping with
How
their
they're
trauma.
coping.
It's how,
Yeah.
yeah, it's what they needed to do to survive. And it worked until it didn't,
Yeah.
until it pushed them so far. And that gave me a whole new understanding of how I approach people with pain. And that helped take, just like when I first learned P&E, like it helped me
Right.
understand people who are in pain. So understanding like the underlying, like the science of it, it
Yeah.
softened me anyway to have more compassion, less judgment, and just, it's just one of the things we say in the sober living houses is healing humans heal humans. Everybody's healing
Mhm.
from something.
Yeah.
And
Yeah. That's
so it's
true. We
just
all have
like
something.
common ground. We all have our stuff. So how
Yeah.
do we just show up together for each other and be kind, play nice in the sandbox, respect one another,
Yeah. That's
So
such a good point. Yeah.
yeah. So it doesn't have to be that different.
Mm.
And this is, again, my kudos to pain neuroscience education, because we are so intentional about creating a therapeutic alliance, creating trust, being aware, being trauma informed. All of the things that we do that go into this position us extremely well to help this population. So it's a huge
Yeah.
opportunity, actually, to support them while recognizing if they're in active recovery, especially if they're early, we might not be the priority, but we can sure support things.
Yeah. You kind of touched on the next question I was going to ask you is, so before any education can be effective, patients have to trust us.
Mhm.
So how do you establish a therapeutic alliance with individuals who have these difficult experiences with maybe like healthcare?
Mhm. Yeah, and yeah, I think for me, I am very. uh, So one of my friends who's an OT talked about the therapeutic use of self. I think Lindsay Marth had talked about that. Like, I am open. I am, I think that people in this population can spot a poser. They can spot, so there's
Yeah.
there's some street smarts that they've got that,
Yeah.
so I'm open. I will say I haven't had the exact same struggle as you, but I have, so I know I'm close with so many people who do. I'm with you. I've got my own stuff. We all got our own stuff. So I try to, like, if when those conversations come up, is connect on the things that we naturally connect with, and really trying to have um, that air of non-judgmentalism. I think to be non-judgmental is a superpower. It's like,
Yeah.
so, and it's something that we can foster the more we get to know people who maybe aren't like us. So
Right.
making an effort, befriending some people who are on this journey, if that I think that's really useful. It's therapeutic alliance. So it's just being who you are, being authentic. In Dopamine Nation, one of Anna Lemke's things for people to stay sober, she encourages her patients to embrace radical honesty, radical
Oh,
authenticity, radical, like just being honest. So that's where I think, now in P&E we will often say honesty without compassion is cruelty. So we're honest and
yeah,
compassionate. Um,
right.
but I do think just showing up with your authentic self is the best we can do in any patient encounter, especially this group, because they can spot a
Our
poser.
patients can tell, like, even if
Yeah.
we're not the experts, they can tell if you genuinely like want to
Yes.
help them.
Yes.
You're on their side. I mean, I know in my pain recovery journey, like even if someone didn't know exactly how to help me in that moment in time, you could tell like they cared for you and they're
Yes.
gonna try and help you as much as they can. And that made the
Yeah.
biggest difference.
Yeah. Yeah. It's funny when I go to family night and if I present or whatever, we're talking, they'll always say, so there's some language and I'm a normie, which means I can consume one drink or two drinks and not get pulled in. So I'm not a substance, I don't, they call people without substance use disorder or, people who are not addicts, they will refer to themselves often as addicts or, whatever.
Yeah.
Um, but they're like, oh, she's a normie, but she's cool.
Oh,
So that's like they're kind of just kind of cute. They're like, oh, look at you.
yeah. So
So it's like
you've been a cute or a cool normie.
cool normie, it's like, oh, I'm not
That's
I'm not real.
you're like,
I
oh
might be
well,
a
that's an
normie, but I don't know
honor.
if I'm normal. Yes,
Thank
I
you.
love it. They're awesome. We have fun.
So one thing that clinicians are always looking for is language to connect with patients. So are there specific stories, metaphors, explanations that seem to resonate particularly well with this population?
Yes, and I'm chuckling here. And if any of my friends are on this webinar, they're chuckling too because they're like, "Oh, language! What kind of colorful language do you use in the family night chess?" Um,
Yeah.
um, so um, I tend to mirror the language of people that I am around. And so sometimes there might be a little bit of swearing because this is freaking hard.
Because
How's that,
yeah,
right?
right,
Like
right.
so that's one like, just mirroring and being at ease with that. Not that you have to do that. Stories in particular, what I would say the story that resonates the most with people is the lions and stress story because that kind of that idea of how there's always something after them and they're always, and they can feel all of these systems and what they had before to help calm down this multi-system, their substance they don't have right now.
Yeah.
Or they don't have anymore and they're never going to have that again. So how do they calm their whole system down now that they don't have that? So that's a
Hmm.
really big opportunity to talk about the pillars. Sleep dysregulation is very, very common as somebody
Hmm.
is going through recovery. The idea that moving, the idea of being mindful and doing meditation, but for some people, that's really scary because if they're going to be quiet in their head,
Hmm.
what are they going to have to deal with that they used to be able to numb out? So,
Yeah, that's true.
um,
That's a good point.
yeah. So I really think the Lions and Stress story has resonated very well with people who are going through this. But it's like anything with P&E. Some stories land well in some people. That's where doing things in a group is really fun with these folks. And then one-on-one, it's really not that different one-on-one. It's just that you have this awareness that there's this other thing that it is also impacting their brain in a very um,
Yeah.
in a way that's going to make your job a little bit harder.
Yeah, that's true. So it sounds like that line and stress story is helping take that complex neuroscience concept and it immediately makes it relatable to
Yeah,
them is a good one to choose.
yeah,
So many, the idea of helping people feel understood naturally brings me to this other topic of many of these patients will have significant trauma histories.
yeah.
So how do trauma-informed care and pain neuroscience education fit together in your approach?
Yeah. So I think, and then this is really important part of the conversation. Um, a few things. We talk about sometimes using like universal precautions for trauma when we're working with anybody with pain, because it's so prevalent, right? We think about the
Hmm.
ACEs study, we think about how many people have at least some trauma. People in recovery, people who are going through substance abuse, many of them have layers and layers of trauma. Some, it's the trauma that got them into substance abuse in the first place because they were trying to regulate their nervous system. Others, it's trauma that has occurred since they've been, they're now they don't have their kids anymore, or they were in prison and this happened, or there's just a lot of trauma. So it's just kind of the basic, you assume that people that many people have it and you treat accordingly. So you give agency when you can. You
Hmm.
position yourself in the room where they can see a door, where they, it's like you, and it's interesting how sometimes this comes up. Like people will say, like, I'm getting triggered, but they're having those conversations.
Yeah.
Absolutely critical is having, if people have a history of trauma, like what are the other supports? Because I'm a PT, P&E. I am not their psychiatrist, psychologist, counselor, any of that, right?
Right.
So, who is on board? Who is on their team to help them process their trauma and heal their trauma? Again, this is that beautiful message of P&E and recovery from addiction and recovery from PTSD. Brains heal. So that
Yeah.
trauma is treatable, but sometimes people like, they need that very directed care. So having a referral pipeline. We actually, when we do family night, um, if I'm teaching at family night or sharing, I would consider it facilitating conversation. I do some teaching, but we do a lot of dialogue in the
Oh,
group.
okay.
Um,
Yeah.
but when I'm there, my friend is there with her partner. Her partner is a trauma trained Gestalt coach that does a lot of work with trauma, and many of the residents have counseling on board. And so
Oh, okay.
sometimes the conversation, if somebody is, really having a hard time, the
Yeah.
conversation might look like, which is great modeling for everybody in the room. This is
Hmm.
something that, is this something that you're actively working on with your therapist? Because if
Yeah.
it's not, you might need to go there and explore that. So the cool thing about the group, and people in recovery are so used to this because they're going to AA and NA meetings or smart recovery meetings. They're used
Yeah.
to talking about their journey with
Hmm.
others. And
Yeah.
they're used to wanting to help each other out. So the magic in the room is
That's,
beautiful. Like
yeah.
sometimes I can't speak to something because I haven't had that experience, but somebody else in
Right.
the room might have and might say, "Yeah, the first time I went to my counselor, I hated it when they made me do this or this, but now I'm like, gosh, I'm really glad they did it." And that opens up that person to maybe trust the system or the healthcare providers or the people that they're getting referred to a little bit more to help with that trauma recovery. But
Yeah.
we don't mess around with trauma. We honor that it is something that is a part of the story that can be healed, but that often takes some work to heal. And
Yeah.
we really point people, it's sort of helping people develop compassion for themselves and responsibility for themselves. That is the
That's
challenge, right? Like, okay,
right.
here's what's happening. And the more they understand about addiction, and same with people who are struggling with chronic pain. Okay, I can see why my body did this to me. It's not being a jerk. People have such an adversarial relationship with their body when they have chronic pain, like my body's
Mhm.
betraying me, blah, blah, blah. Well,
Right.
but it makes sense. Can you see why your nervous system would have wanted to protect you like this? Same
Mhm.
thing with addiction. You just told me your story. Whoa. I can see why. Can you see why this thing this being wants to just survive and how it chose to do this and it
Yeah.
worked until
Yeah.
it didn't. You know, pain
Right.
works until it doesn't. Addiction
Yeah.
works. Like it works
Good.
until it doesn't. So,
So it sounds like, yeah, to me, like you can't ignore one or the other. It's like they're kind of feeding off each other. So you gotta address that trauma if you want to also be able to address the pain
Yeah,
and
it's at
that,
the root. It's at the
yeah.
genesis of so much of this.
Yeah.
So, but it requires a skilled trauma therapist who
Right.
knows, I'm not going to be a poser and go out of my scope of practice and think that I can do this, this, that, and that. I don't treat trauma.
We don't have enough
I
hours in the day. Yeah.
no, I treat pain, but I know in my
Right.
neighborhood who treats trauma, and I point
That's
people
so
in that
great.
direction.
Yeah.
So,
Yeah. Okay. So progress may not always look the way we've traditionally measured it, like in a regular orthopedic clinic.
mhm.
So when you're working with someone in recovery, what outcomes matter most to you? And has this work changed like how you define success as a clinician?
Definitely. So if I'm seeing somebody in my office with addiction issues, but they're coming to physical therapy for pain or for improved movement, then my outcomes are the same, right?
Yeah.
There's someone who has a comorbidity of addiction, and
Yeah.
but we're still looking at the same outcomes. If I am going out into, well, and that means whatever the person's goals are is
Hmm.
that's what's the most important. Remember, I said their goals might be different. It might be, I just want to be able to visit my kids. Like I want to just be able to walk. I've had people who I just want to be able to walk to meetings. I have to go to meetings. I don't have my driver's license
Oh,
anymore
yeah.
because that's been, I've had too many DUIs. My goal
Right.
is to walk to a meeting. So
Hmm.
it might frame kind of what the goals look like. Um, but if I'm going to a family night, to a facilitated conversation, the outcome that's not really it's not really a intervention that's going to have an outcome. It's a conversation that's going to lead to understanding and aha moments. And so that, how do you measure that? This is something I'm doing with my dear friends to help make our community better. So what does success look like? It looks like when I show up at a family night or a reunion night and we have somebody who comes back and 2 years later they're still sober and they're going to the gym now because yeah, remember we had those yeah, you told us motion is lotion way back then and I finally got off my butt and I'm doing it. Like
Right.
that's a
Yeah.
great outcome, but it's measured
That's
in
huge.
stories. It's measured in
Yeah.
stories and individual pursuits. I don't, I'm not keeping score or records or anything like that.
Yeah.
'Cause this is community service. This is, this is something
Yeah.
that's just a passion project. I don't get, well, I don't, this is just what I do with my friends. So,
Yeah. Um, how about how do you help patients recognize progress when pain levels like haven't changed much yet? Mm.
well, I think that again goes back to kind of your basics of P&E is if they're patient and you have done a good eval and you have your good baseline measurements, you can reflect back and say, you know what, I know your pain is still where it's at, but do you remember when you first came in? Let me open up my chart and look at, you could walk, hmm, you could walk for 5 minutes max.
Hmm.
You're making it to and from meetings right now. I know you
Yeah.
still hurt, but that's a 20-minute walk, right? So,
Yeah.
and it's interesting because in the recovery world, it's the same. It's reflecting back. I saw you. I remember that first day you came into the doors here. I remember, like, I can think of patients right now, like, or people, not patients. I've never saw them as patients, but the first
Yeah.
time I ever went to teach arms crossed, where I'm like, whoa, I'm kind of scared
True.
of her. And 6 months later, that's we're tit and hugging and like doing a little dance together. Whatever.
Yeah.
We've had great fun movement nights for family night too. So
Oh,
yeah,
yeah. So that's yeah, that's such a powerful perspective when you go from focusing to like fixing someone to just helping them reclaim
yeah,
meaningful parts of their
yeah,
life.
yes.
Um, for clinicians today, listening today, who would you want to better support patients with current or past substance use disorder? What's like one thing you would encourage us to start doing tomorrow?
Hmm. Um, I think, it just depends where you're at. If it might just start with some self-reflection. Just
Yeah.
reflect on yourself and what do I believe? What do I understand about substance use? And what do I believe about it? I was, and I know I've mentioned Anna Lemke, she is just a hero to me. But what I really appreciate in her book, in Dopamine Nation, she starts out with her own story and kind of her own like slippery slope of something that she was challenged with and how that perspective helped her frame the whole story. So I think that starting with a little self-reflection of, do I have a tendency to other the addict, other the substance use, other the, if there's any, and and I'm not coming down on anybody who has any frustration around that because we all come to this with some baggage because this stuff is hard and there is hardly a person that I've ever talked to who hasn't been impacted in a really difficult way by somebody in their family, friend group, something
Yeah.
who struggled with this. So I think kind of making peace with the idea that addiction happens,
Hmm.
pain happens, right? We make peace around that. This like we accept that that is the situation. And so I think some self-reflection, and then maybe if you're interested in it, exploring some resources, learning more about addiction. And
Hmm.
then, and if it's something that you have a lot of comfort with, and this sounds like, yeah, I get this, then maybe look around in your neighborhood, look in your hometown, or is there a place for you to dip your toe in the water and say, hey, I have some stuff. I know pain, I know the brain.
Yeah.
I'm learning about addiction, but I'm interested in helping. And so there's a huge untapped potential here to be resources and supports and actually just to have fun and engaging, authentic, transparent conversations. It's so
Yeah.
fun. There's some of the most fun people, and they're just finding their fun again outside of of the substances. So
Yes. Sure. Yeah, that sounds like a great place to start. Like just reflect and see. I mean, I know I might have biases that I don't even know that are there.
mhm,
And just meeting them where they're at,
mhm.
listening to where they're coming from.
Yeah.
Um, so I'd love to get your perspective on the bigger picture. What gives you the most hope when you think about the future of pain and recovery focused care?
Well, what gives me the biggest hope is seeing the radical transformation that is possible thanks to this living, breathing, dynamic thing we have called a nervous system. It
Yeah.
can heal,
Yeah.
and it heals best in community, and we
Yeah.
get to be a part of that. And it is just such a cool thing. And so, um, the more we start working together toward that wholeness of a community and stop othering each other, and we just come together and we say, yep, well, here's how I'm broken. Here's how I'm broken. Here's what oh, okay, well, we all got something. Like,
Right.
tell me your story, and then what can we do to grow? And there's so much room to grow. So I think the thing that
Mhm.
gives me the hope is that there is so much room to grow. There's so many avenues. There's pillars that we can work on. But just the idea of doing it in community is the thing that excites me the most. I think this is what the recovery world has to teach the pain world, how
Yeah,
much community can impact recovery. So,
that's
so
true.
is the magic is in the room. It's around the table. It's when they're, it's the support, like everybody rooting for each other and saying, well, this is what worked for me and this was helpful. And oh man, I see you. I remember when I was there. That was so hard. Like there's
Yeah,
just
that's
validation there
just
that's really
right.
cool.
Yeah, I think that's such a hopeful message for clinicians who maybe feel a little like uncertain working with this patient population.
Mhm.
Um, yeah, that's such like a powerful thing that
Yeah.
we can do. So before we wrap up, I'd love to kind of bring everything to life with a patient example.
Yeah.
So can you share like a patient story that illustrates the impact of the peony?
Yeah.
Um,
Yeah, I actually have a big one. I asked his permission to share it. I said, I won't use your name. But he is someone near and dear to my heart. And I remember meeting him probably about 2 years ago at a family night. And and he was just skeptical. We were talking about, I think we were talking about sleep at that time in that one.
Okay.
I might have a few different talks that I do, and I probably go in once every other month. And he's just kind of that closed, like,
Yeah.
down on himself one. And this gentleman is 6'7". He's a tall,
Oh,
and he was probably about 450. I mean, he was a big dude and had really, really horrible chronic pain in his feet. He had had bilateral foot fractures and whatnot. And I saw him at the first one, and he was early in his sobriety. And then saw him a couple months later, and he was, at that one, I'm not sure what the topic was, but the house manager encouraged him to have a conversation about his feet with me. And I said, dude, I'm happy to sit down and talk to you about your feet. Um, and so he did become a patient. And the first visit, I sat down, did the, sensitive nerve, used the cards, did all of the traditional stuff.
yeah.
And he was tracking, and then no, he just didn't, like he was, but didn't schedule again. But then I came
Oh,
back into the house for
yeah.
another, just regular touch. And it was that third time that I was in the house and he'll say it to this day, it's like he finally trusted that I wasn't peddling something, that there might be something, like the trust had to get earned. And so then he came back. And what was so interesting, he was on the fence. Part of the reason the house manager wanted him to see me is he was considering elective amputation of his feet because the
Oh,
severity of the pain. He could not walk.
yeah.
He was just in such rough shape. But as he was moving through his recovery, starting to feel a little bit better,
Yeah.
in terms of the addiction, it opened up a little space for him to take on the pain science stuff a little bit. And
Oh,
so
good.
we did he came in, we did the regular stuff. We did the paced, like pacing was so huge for him. And literally wrote out a weekly schedule for him to address both the specific things that were going on with his feet as well as the global things. And um, he worked the system, he worked the plan. He trusted the process and worked the plan with a lot of reinforcement. And then even when he couldn't come in overly, it's not like he could come in at a high frequency. He had a lot of other things going on. Um, but he worked it. And about a year later, he told me he played pickleball. I'm like, what? So he's doing
Yeah.
great.
Wow.
And his recovery has been so profound in his substance use. He's now a house manager and by the way,
Oh,
my friend has opened 4 sober living homes, 2 men's, 2 women's so
oh,
she has grown, her
he's
and her
doing great.
partner.
Yeah.
Yeah, so it's a movement that's just happening in my community, and I am just so fortunate and blessed to be part of it. So it's
Yeah.
really cool.
Wow. That's a remarkable journey.
Yeah, yeah, it's a
For-
cool thing. Yeah,
Oh, thank you.
he's had a transformed life, and he's so thankful for it. And he is totally hot to trot for the biopsychosocial model. He is teaching this stuff. He is taking it and
Oh,
just storing it. So he's
yeah.
bringing it to his houses.
His his community
Yeah,
and
yeah,
yeah,
he's
bringing
all
hope,
in.
being hope for other people
Yeah,
and
yeah,
yeah. Yeah. Oh, thanks so much for sharing that.
yeah,
Yeah, I think that story captures like so much of like what we were talking about
yeah,
today.
yeah.
Kind of brings
Initial
everything together.
initial resistance and just didn't have the bandwidth. Like when you're
Yeah.
early, but when space opens up and trust is built, there will be something that takes root. And it was having that very tangible plan, a written down, pacing plan, but he had to understand how, because he was just so go big or go home. I will say that for our
Oh,
addicts, there's a
yeah.
lot who are go big or go home.
Yeah.
So, yeah, so
So the pacing is what worked for him.
yeah,
Okay, well, I think that's all we have time for today. So as I look back on today's conversation, one thing that I keep coming back to is how easy it is to just like see the diagnosis before we see the whole person. And we talked a lot today about pain neuroscience education, trauma-informed care, the nervous system. But underneath all that was something much simpler. It's just people want to be understood. Um, and they want someone who's like curious, someone who's willing to listen before just like trying to fix, someone who just sees the diagnosis more, that they're more than the diagnosis or their past. So I
Yeah.
think that's something every clinician, and myself included, what can carry to the clinic tomorrow. So, Jessie, thank you so much for sharing your wisdom and experience with us today. And thank
You're
you.
welcome.
Yeah, I loved hearing all of it. I wish I could talk to you for another hour. And thank you everyone for listening to us. Next month, we'll be joined by Eric Rabin to explore incorporating pain neuroscience education as the navigator within a multidisciplinary spine team. So until then, thanks for listening, and we'll see you next time. Thanks so much again, Jesse. I
Yep.
enjoyed all
Thanks,
of it
Christina.
today.